This morning, we are going to be listening to a review of well-supported substance abuse prevention and treatment programs on the Title IV Prevention Services Clearinghouse. Our presenter is Jennifer Rolls-Roots, and I would like to do a brief introduction of Jennifer. Jennifer is the director of the California Evidence-Based Clearinghouse for Child Welfare, or the CEBC, and she's the director for the California Training Institute. Both are based at Rady Children's Hospital. Before these roles, she was a research coordinator at the Child Adolescent Service Research Center, also based at Rady Children's. And her work has always focused on children receiving services through public sectors of care, including child welfare and mental health systems. Jennifer, I'm going to turn it over to you.
Great, thank you. Very glad to be here, and thanks for having me. So I'm very happy to share information on the programs that will be available in California through the FFPSA funding. And for those of you who have attended the other 2 webinars in this series, it's going to be a little bit of a repeat at the front and the end, but hopefully it's just some reinforcement of what we've covered. Okay. So let's get on in. Oh, first of all, for those who are not familiar with the CEBC, the mission of the CEBC is really to help spread the use of evidence-based practices within the child welfare system, as well as other child and family serving systems. And the CEBC has 2 main components, the program registry and the implementation section. So while I'm with the CEBC and CalTrin, I'm going to really be talking about the FFPSA rated programs. So I'll take off my CEBC cap for a bit and we'll kind of go on from there. So first, I want to get us started with getting some information about who's here. So from Dana, if you can go ahead and launch that poll, that'd be great. Tell us about the region that you work in. And if you have a statewide role, there's something for that. If you're outside of California, tell us that, and then you can put that in the chat as well. I know we have a few people from out of state. Great, I see stuff coming in. We'll give it a second. I think when we hit like getting almost to 80, once we hit 80, we can go ahead and share the results. I don't want to keep us waiting too long. Okay. There we go. Great. All right, want to share those results? So we've got a representation from across the state. That's good. Perfect. Okay. And actually, we have a pretty good split. Bay Area, Central, Mountain, Southern, and then a good number of folks from outside of the state as well. So again, feel free to put that in the chat if you want to share what state you're joining us from. All right, you can close that, Dana. And then we're going to move on and do one more poll that helps us know kind of what is your role. So what types of folks are joining us today? So our options are you direct service, frontline, any sort of direct service? Are you administrative, analyst, technical assistants? Are you more of like a lived experience, advocate, peer partner, community representative, manager, program manager, or anything at a director level? So thanks. I see we got numbers coming in there. I'm going to grab some more coffee while we're doing this. Okay, let's give it another minute. And then Dana, why don't you go ahead and close it and share the results? Okay, so again, about a quarter of the folks are more direct service, frontline. We got a quarter who are more administrative analysts, and then program managers and managers. So, and if you put other, feel free to drop something in the chat. But yeah, a good variety of folks at different levels. So hopefully we can give you some good information today. All right, thank you. That's helpful for me. All right, so I guess on to the next slide. Let's do a quick review of the agenda. We are going to be covering FFPSA Part 1 and the California Plan, which actually includes more than just FFPSA, so we'll get to that in a moment. We're going to review the well-supported prevention and treatment programs, substance abuse prevention and treatment programs on the Title IV Prevention Services Clearinghouse. We'll go over each one of those key components, what are the requirements, and give you some places to get more information. And then we'll spend the last half hour kind of talking about the CEBC program selection tools that can be used to help your agency determine which of those options might be best for you, or you can still use the tools for any sort of selection purpose, even outside of FFPSA. Okay. All right, so let's start with what FFPSA is. So hopefully most of you have at least heard of it, but in case not, I'll give a very brief overview of it and also its rollout here in California. FFPSA stands for the Family First Prevention Services Act, and it was enacted in 2018. So to give you an idea of kind of the context of this training, we're really talking about FFPSA Part 1. FFPSA has a whole bunch of different sections. You may be familiar with FFPSA Part 4, which has more to do with congregate care, STRTPs, et cetera. Not going to talk about that at all. And we do have some resources on FFPSA on the California CDSS website. So Dana will drop a link. So if you want to learn more about the broader FFPSA, that's probably the best place to go. We also aren't going to get into detail about the FFPSA rating process for programs. It's pretty complicated and a lot of minutia. So I'll be directing you as we get to those points to the FFPSA Prevention Services Clearinghouse website for more information. We'll touch on it, but again, not going into a huge amount of detail on that. And then lastly, we're going to give you a quick overview of the California Comprehensive Prevention Plan process. Lots of other resources available. There's been a few webinars already in the Reimagining Prevention series that have covered it. So again, we're going to give you a flavor of it, a quick overview, and then give you information about or links to where you can go to get more detailed information. All right, FFPSA Part 1 passed in 2018. And so for today, again, we're covering the Part 1 provisions, which offers federal Title IV funds to be used for very specific evidence-based services for families where a child is at risk of foster care, out-of-home placement. And for those who are familiar with the system, previously we had waivers, Title IV waivers or demonstration projects in California that you could use Title IV funds to provide services kind of similar to this. The waiver program ended in 2019, and really FFPSA Part 1 is allowing us to make use of Title IV funds again under those very specific criteria. And that has to do with children who are considered at imminent risk for out-of-home placement, as well as services for their family members to prevent that out-of-home placement. It also includes services to pregnant and parenting youth and their children. So pretty narrow criteria of who can be served under FFPSA Part 1, but a great way to start using some of those Title IV funds that were typically for only out-of-home care. Now we can start using them to prevent out-of-home care. Right. What can be funded under this? As we said, it's evidence-based interventions that are funded under FFPSA need to meet certain criteria. So first, they have to be listed on the FFPSA Prevention Services Clearinghouse. So Dana, if you can drop the link to that. And again, this is the place to go for all the detailed information. Basically, the eligible services that are included under FFPSA Part 1 are in-home parenting programs, which we did a webinar on last week. You can see a recording. Mental health prevention and treatment. Again, we also did a webinar on that. And then today we'll cover the last category, which is substance abuse prevention and treatment. Additionally, the FFPSA Part 1 does include the ability to evaluate services with the eventual goal of getting them rated and included in that federal prevention clearinghouse. And the last criteria is that whatever the service is must be listed in the California plan. Currently, there are 10 well-supported programs that are in the California plan. And so those are the ones that we've been covering in this series. Okay. FFPSA Part 1 is intended to reduce entry into care. So get kids, reduce entry into out-of-home care, really by addressing safety threats while children remain in home with their families, with their caregivers, family of origin. Okay, so that's the ultimate goal, reduce entry to out-of-home care. And so it is not primary prevention. So a lot of times people hear that title, Family First Prevention Services Act. Really, this is, a little bit further along. And so it's more secondary, tertiary prevention. So there's a little bit of, concern that we're not doing more to prevent maltreatment in the first place. So to respond to that, really what California has done is passed a broader bill, Assembly Bill 153. And while it supports the implementation of FFPSA in California, it also expands upon the funding available under FFPSA by offering additional optional funding that requires counties to engage partners, stakeholders, in the development of a comprehensive prevention plan that includes primary, secondary, and tertiary strategies, all in addition to those that can be funded by Title IV-E under FFPSA Part 1. So it requires that cross-sector collaborative approach, bringing in your community partners, your CBOs, public agencies, tribes, individuals with lived expertise, key partners, et cetera. So really getting the community together at the county level in California, because we're a county administered child welfare system, to work together, really in the goal of broader prevention, primary, secondary, and tertiary. So the two statutes, FFPSA and AB 135, really work together in California, and California is calling it their Family First Prevention Services Program, or FFPS. And it recognizes that we're not starting from scratch. Many counties have already been working for several years with OCAP, the Office of Child Abuse Prevention, and Strategies TA to build local capacity for prevention. I think we have 22 or 24 prevention planning teams at the county level that have already been working on this. So we want to support and provide additional funding for those efforts and help expand opportunity for more jurisdictions to participate in those prevention planning efforts. And the last thing I want to point out here is that final bullet, which is California's plan gives access to what we're calling a community pathway approach for service delivery for early community-based services. So this will allow families to receive services that are funded through these dollars without actually having to go into child welfare. And so again, lots more detail on all of this in other webinars, but just wanted to give you a flavor of kind of where the state is going. This is a roadmap that the state has put together for their comprehensive planning and implementation process. And I think we'll drop a link to that as well. It's an overview that really shows where the state is going. There's going to be technical assistance throughout the entire process. The webinar series that we're doing is really in this leftmost side, guidance and information. So we're working to get out information about the plan itself, the funding streams, the interventions, et cetera. So lots of information sharing. And then counties are opting in. There's an opt-in process. I think it's due on the 30th, so we're getting close. But if counties, need a couple extra days, I'm sure the state will be reasonable. Just work with your county, your state partners. But you can learn more about this roadmap and the entire process through the webinars, and Dana has dropped the link to those. Okay. All right, so why does all this matter? The reason I wanted everyone to understand the comprehensive prevention planning process and its role in the fact that there's more than just FFPSA Part 1. Because the programs that will be implemented under this umbrella program of prevention will be selected through that comprehensive prevention planning process, which has to involve stakeholders. If you look at the materials, it's clear they have to involve community. That means FRCs, Family Resource Centers, Child Abuse Prevention Councils, CEBCs, community-based organizations, all need to be involved in that plan and help drive what gets decided. So we want to make sure that partners across the board are hearing about what's available for funding under both FFPSA Part 1, as well as under the very broad funding through AB 153. And clearly, if you are a community-based organization, this is a new potential funding source. So we know that it's a struggle to find ways to fund your prevention services. Prevention is a little bit harder. Here is a whole new source of funding. And you can look at the allocations by county, et cetera, through the links that Dana has dropped. All right, so today we're going to talk about what's available for funding under FFPSA Part 1 through those Title IV-E dollars. We've covered mental health services and in-home parent skills-based programs already. Today we're going to talk about substance abuse prevention and treatment. And let's just define what this means. Has to have an explicit focus on prevention, reduction, treatment, remediation, elimination. Very broad. So as you can see, it's very broad. These are services for both children, adolescents, and their families. So they kept this pretty broad. It can target any type of substance abuse, multiple substances, address stuff in general. The criteria are very broad. The only thing that's not eligible is anything that's solely reduced at tobacco use among adults. So this is not a prevention to reduce smoking among adults, et cetera. Among kids, yes, that's fine, but it's not tobacco use among adults. Pretty much other than that, any other substance is covered. All right, so what other requirements? It has to be delivered to children and youth, adults, or families. Again, very broad. And each therapeutic modality. It has to have some sort of therapy component. It can be any type, any orientation. It can include a medication component, but only if a therapeutic component is also included. So for example, a treatment that used methadone cannot be, a treatment that uses methadone for the treatment of opioid addiction without an accompanying therapeutic element would not be covered under this. It can't just be medication only. Medication plus therapeutic services, that's okay. All right, so there's the criteria that the FFPSA legislation has. They also have well-established criteria for the ratings. And in this case, we're focusing on the well-supported programs, the top rating on their scale. And what this is about is contrasts. So basically a contrast, their requirement is that it has to have at least 2 contrasts with non-overlapping samples that showed a favorable effect. All right, so a contrast is kind of a weird term. It's just a comparison. So if you think about studies like a randomized controlled trial, a contrast is a comparison group and a treated group and a comparison group being looked at for one outcome. So for example, a study with an intervention group, and then a comparison group that reports results on, let's see, the child behavior checklist total score would be considered one contrast. If they have a second measure on that same study, let's say they use the IBERG child behavior inventory and the CBCL, and they show results on that, those are 2 contrasts. So it's really, the term contrast just means comparisons on some sort of outcome measure. So in addition to having it to show at least 2 favorable outcomes, they also have to have had a sustained favorable effect of at least 12 months beyond the end of treatment. That really means that we want to make sure these services continue, that the effect continues after the intervention is done. So if you're delivering substance abuse services, you would want to see that there is some effect that continues, 12 months out from the end of the intervention. You can still see an effect. All right, so 3 programs are currently in the California plan under substance abuse prevention and treatment. So we will cover each one in detail to give you a flavor of what they are. But first, let's just drop a quick poll, and Dana, if you can launch that. Let's see which of these programs are you least familiar with? So let's see, I'm just always curious what folks are most familiar with. Let's go the opposite way. Which one are you least familiar with today coming into this? Okay, so we're kind of neck and neck here. This is kind of interesting. All right, so brief strategic family therapy, Bsft, and multisystemic therapy are kind of tied. And clearly people are more familiar with motivational interviewing. So Dana, if you want to end that share, thank you. Yeah, so we got, it's pretty tied. So we're gonna give you a good overview of each. I've got a couple of videos that I think will be interesting. And then we'll have time for questions at the end. All right, let's launch right into it. Brief strategic family therapy. I've given you 2 URLs here, 2 addresses. Brief strategic family therapy is actually supported by 2 separate organizations. It's my understanding that these were kind of partners that developed this together, and then over time have kind of not split up, but they both have their own independent support arms. So both of those places can give you information about Bsft and help you implement it. So what is it? Brief strategic family therapy uses a family systems approach, so family therapy, to treat these families with children and adolescents who are either having issues or are at risk for developing problem behaviors. 3 main intervention components. The counselors work with the families to kind of understand what the family is undergoing. There's observational components in there as well. And then they're really trying to educate the family on how to relate to one another in more positive ways. So it's definitely a very family-focused approach. Okay. I'm going to share a quick video. This is from a program in New York that is delivering this. And let's just see if we can get these to play. Okay, it is not playing for me. We're going to give that another 30 seconds, and then if we can't, we will move on. All right. All right, I think we're going to skip that. Sorry, Dana's going to drop a link to that video, and hopefully some of the other ones will work. Sorry, they worked when we ran through it this morning. Okay. Bsft targets children and adolescents 6 through 17 years who are at risk of these problem behaviors, could be drug use, antisocial, bullying, etc. It is a short-term intervention, 12 to 16 weekly sessions, some flexibility depending on family need. And the goals of Bsft are to reduce behavior problems, improve self-control, reduce associations with antisocial peers. So it is a family-focused intervention, reduce drug use, and help develop more pro-social skills. And for the family, I think the first one is probably the most important. It's improve family functioning. It is, can you improve your maladaptive patterns of family interactions? Can you help the family communicate better? Can you improve the cohesion, how well the parents and child get together, work together? And can you improve, parenting in general to help them be more successful? The essential components of Bsft are to, again, address that family behavior, to address the way that, affect and cognitions are happening in the family, with the goal of restructuring interactions and changing that family system. And again, like what they say is the focus is on context versus content. Each family has an individual plan, and it's based on their own assessment and their own, diagnostic, their own individual issues. So the therapeutic process of Bsft uses the following techniques. Joining. I'm not going to go into all of these in detail. Actually, on the CEBC website, there's probably a better description, but they're going to use the techniques of joining, enactments, a systematic diagnosis, so a clear assessment that leads to a diagnosis, and then treatment planning based on that diagnosis. And then a couple of things that are very specific to Bsft, restructuring, implementing those change strategies that they came up with in the treatment plan, something called the Bsft systemic cognitive change, which is reframing, but again, using their own specific process. And then lastly, what they call the Bsft engagement model. So more detail on all of this on the Bsft websites that we gave you earlier, but also on the CEBC if you want more information, and on the Prevention Services Clearinghouse. One of the areas that we look at at the CEBC with any evidence-based practice is what support does the intervention provide for actually implementing the program? What do they have available to help you decide, is this a good fit for you? And then if you do pick it, what do they have to support its implementation, its correct implementation within your agency? So we're going to cover kind of 4 categories of support for implementation for each program today. The first one is pre-implementation materials. Do they have assessments? Do they have guidance? Do they have any sort of materials that can help you determine whether this is a good fit for your own agency? Do they have formal support available? Do they have an organization, a person, someone who can support you individually as you implement the program? Fidelity measures. This is very important. Do they have tools to help you see if the intervention is being delivered the way it was intended? And then lastly, do they have guides or manuals, written materials that you can refer to that are specifically about implementing the program in your agency, dealing with common challenges and barriers, funding issues, et cetera, the day-to-day setup type stuff that you need to consider as you're rolling out a new program. So for Bsft, as you can see from the slide, they do have pre-implementation materials. They have site readiness, and they have organizational readiness processes in place. They do have formal support through both of those organizations that were on the intro slide. They have fidelity materials, and the fidelity assessment is required. You actually do need to supply this information to Bsft. And then lastly, they do have implementation guides and manuals available. So overall, a fair amount of support for implementation for Bsft to help you as you're rolling this out. In terms of the training requirements, we're looking here at a master's degree in social work, related fields, MFT, psychology, et cetera, and experience. They do allow for bachelor's level people who have more years of experience, more on a kind of a case-by-case basis in collaboration with the Bsft folks. The training can be offered either at the trainee organization or online. One of those few benefits of COVID is that we've all moved to doing a lot more things online than we used to. And so training is available online as well. Lots of different components, as you can see: didactic, videotape analysis, presentations, supervisions, et cetera. So multiple components of training for this one. All right, this next slide is really just to give you an idea of where the studies on Bsft, or on the 3 interventions we're going to talk about today, have been conducted. We often hear concerns from people that, any particular intervention may have only been studied with very narrow populations. So what I've done here is just pulled a couple of examples of where Bsft has been studied to give you an idea of the sorts of populations that it has been tested in. Bsft was largely developed in Miami, the University of Miami, which you may have seen earlier. And so not surprisingly, we're seeing a large percentage of Hispanic populations. There was actually one study that was completely Hispanic and actually reported on the nationalities of the youth who were involved, et cetera. The purpose of sharing this is just to help you think about how similar or different these populations are to the ones that you work with. In these examples, the participants, the parents and adolescents, in one study, the parents and adolescents had been referred for drug treatment at community treatment centers. In another one, they were either self-referred or referred by the school counselor, and of course had to meet some basic inclusion criteria. So just a variety of ways that folks are getting into the system to give you a little bit of a flavor of who this intervention was studied on. All right, so now let's get to the extent of the evidence as determined by the FFPSA Prevention Services Clearinghouse. First, what they do on the clearinghouse is a full lit search. So they go through all the literature that's available, and what they found in this case is 6 studies that have been conducted on Bsft. In the Prevention Services Clearinghouse, they have criteria of what types of studies they will review. And so in this case, one of the studies of those 6 did not meet the criteria, and so it was excluded from review. And then within the studies that they do review, so the 5 studies that were eligible for review, each of those studies then gets rated high, medium, or low in terms of the design and execution standards. Okay, so again, it's a pretty complicated process. Dana has dropped a link if you want more information. But basically, a highly rated study is considered higher quality. A low study, lower quality, probably had some issues. Okay, so in this case, 1 study of the 5 was rated high, 1 was moderate, and 3 were low. Let's take a look at the findings among the 5 studies that they reviewed. We'll break it out by child and adult. So what we found here is that there were favorable effects, or they found 1 favorable effect. Again, remember, this is contrast. So comparisons between an intervention, a Bsft group, and some sort of comparison group. So they found a favorable effect on child behavior and emotional functioning. I think that was actually on the DISC, the Diagnostic Interview Schedule for Children. They did not find anything for children on substance abuse, although they looked at 17 different contrasts, but none of them had a significant effect. Delinquent behavior did show favorable effects, and that was related to arrests and incarceration rates, for example. Again, you can see all of this detail study by study on the PSC Clearinghouse. On the adult side, again, we found a couple of favorable effects on parent-caregiver substance use. That was on the Addiction Severity Index light alcohol use area, and then also on family functioning. So a measure of, I think it's the Structural Family Systems Rating, did show a favorable effect. All right, so that is the wrap up of Bsft. So I was just going to check, Dana, if there were any questions that have come through that we want to cover at this point, or hold them for the end.
We do have a question.
Okay.
It is, can you explain slide 22? It sounds like any substance prevention program or intervention can be funded, not only the 3 identified.
Under FFPSA Part 1 in California, it starts to get a little confusing because there's lots of components to this. So again, we're focusing on California. California only identified the well-supported programs for funding under FFPSA Part 1. So at this point, that's what they have in their plan. Every state is a little bit different on how they have developed their plan. So depending on where you're coming from, they may be different. Keep in mind, this is just FFPSA Part 1 funding. So under the AB 153, the broader umbrella funding that California put in, I'm not going to say anything goes, but it's much broader than this. Okay, so hopefully that helps. And happy to talk offline and connect to direct links on that as well. Okay. Any other questions?
I think we are
right.
set to keep going.
All right. I will keep us moving. We're going to try another video. We're going to see if this one works for me. I'm kind of bummed because I love this one. Motivational interviewing, or MI. And it sounds like folks were more familiar with this one. So there's the link to it. What's interesting about motivational interviewing is it's a little bit looser in terms of how it's being disseminated. There are lots of different trainers across the country who train on it. And you'll see when we talk about the training, it's not quite as strict as some of the other ones. So let's just see if we can get this slide to play.
Jennifer, we're missing sound.
We're not getting sound?
No, I'm going to go to the top of your screen and check that the sound has been set to the video.
Okay, so it sounds like we're not getting sound. So I think we will continue on. Dana, if you can drop the link, we will keep going and hopefully we can figure out why this is not working for me today. Okay. All right. So motivational interviewing is really a method of counseling clients. It's designed to promote behavior change and improve a variety of outcomes. So it can be used to, as we say here, identify ambivalence for change and increase motivation. It's actually used for a large number of treatments, not just substance abuse, or a large number of issues, because it is really trying to promote behavior change and get people to kind of move through those stages of change by thinking about their own personal goals and how their current behaviors may be competing with what their actual goals are. Okay. And Dana, I don't know if we have a link to the recording of the MI webinar that we did on CalTrin, but we may want to drop that at some point if folks want a much more detailed overview of MI. We did a webinar a couple months ago.
Perfect. I'll drop that now.
All right. All right. So motivational interviewing can be used with pretty much any target population. And it's used for a variety of different reasons. It really was started in the substance abuse area to help encourage people to make that change and examine it. But now we see it used as an engagement technique in a wide variety of areas. Under FFPSA Part 1, it's in the substance abuse category. Motivational interviewing is typically pretty short, 1 to 3 sessions, and it can vary if it's being delivered in conjunction with other treatments. So you'll often see motivational interviewing embedded with a substance abuse intervention or with a mental health intervention, et cetera. Okay. And the goals are really to enhance that internal motivation to change, really getting at what do you want, and do you want this change, and reinforcing that motivation to make that change, and then developing a plan. So Dana dropped a link if you would like to learn more about it, or you might want to introduce it to your staff. The webinar that we just did, I think, was a good introduction to it. I'm going to skip right over the video. I'm not even going to try this time. So Dana, if you want to drop the link, or I think it's going to be in the follow-up materials as well. I don't want to take too much time on that. All right, so MI is really getting at 2 dimensions related to ambivalence to change: the importance of the change and the confidence that that change can actually be accomplished. And it's working on those open-ended questions, talking about it. It's moving people farther along on that continuum of change. So here are some examples, that might be used. What worries you about your substance use? What kinds of things would need to happen to make you consider changing? So very open-ended, and getting the person to, give their own, their own answers to these questions, helping them work through their own ambivalence. And then utilization of a lot of listening statements, focusing on their own language about change, to get them to really think about what's going on and be able to make that change. Okay, so as I mentioned, motivational interviewing is definitely a little bit looser, I think, than Bsft in terms of the way it's disseminated. It's much more broadly available in terms of the number of trainers, but we were not able to find any pre-implementation materials or assessments available. There is formal support for its implementation through what's called MINT, the Motivational Interviewing Network of Trainers. And that's that link that we gave you at the beginning, motivationalinterviewing.org. There is a Fidelity tool. It's called MITI, Motivational Interviewing Treatment Integrity. And then they do have implementation guides. So it's a little bit different in terms of how it's disseminated. In terms of education requirements, no minimum qualifications. It can be used by pretty much anyone who's trained on it. And the training is done either on site or virtually. There is not a single specific training. The MINT website lists trainers by state, along with current training offerings. And the training can be a little bit different depending on the specific trainer. To give you an example, on CalTrin, so we just did a series on motivational interviewing. We started with, I believe, a 2-hour intro webinar that gives everyone the basics and a little bit of flavor of what it is. And then, Dana, you can correct me in chat if I'm wrong, but I think it was a 5-part small group series where they were much more intensive, role-playing, breakouts, et cetera, actually practicing the skills. So it definitely is one of those interventions where you have to practice those skills and kind of learn that process. Studies of this, it has been studied. There's a huge number of studies, but just a little bit of a flavor. Here we had 2 studies. One was largely white, 16% other, another 67% Caucasian, 10% African-American. I should note I'm using the exact wording from the papers, so that's why there's differences between them. And then the study samples, examples, recruited from the community, incoming college freshmen, women from primary care clinics. So all different settings this has been recruited from. And the review of MI by the Prevention Services Clearinghouse identified 206 potential articles. So lots of research has been done on MI. Of those, 75 were deemed eligible for the Prevention Services Clearinghouse review. One thing I should note is that when the Prevention Services Clearinghouse identifies more than 15 studies, they do review all of them for a risk of harm, but they have an algorithm for how they identify which are the 15 studies that they will really look at in more detail. Okay. And so in this case, a large chunk of studies were only looked at for harm. But there were still a good number of their studies that were rated high, moderate, et cetera. All right, so let's go through here. In child findings, really the main area that was looked at was substance abuse. And there were no favorable effects found on child substance abuse over 33 different contrasts that were examined. On the adult side, much stronger findings, particularly, not surprisingly, in the area of parent or caregiver substance use. So we found at least 16 favorable effects, and these are, statistically significant positive effects on things like number of drinks per week, heavy drinking, alcohol dependence scale, the audit, the alcohol use disorders identification test, marijuana use, opioid. So a wide variety of outcomes were looked at. But they did not find favorable effects on parent caregiver criminal behavior or mental or emotional health. They also looked at family functioning, physical health, economic housing stability, and didn't find anything there. Okay. All right, so we're at the end of our MI piece. Dana, any questions on MI before I go on to the last program?
Not at this time.
All right, good. Last one, multi-systemic therapy. All right. Oh, and I'm just realizing that we are missing the URL for that. So we'll be sure that we get that out. I must have dropped that off somehow. I believe it's mstservices.org off the top of my head, but we will be sure to add that to the follow-up email. Okay. All right. So multi-systemic therapy. This is a very intensive treatment for what they call troubled youth. Can be delivered in a variety of settings. And it aims to promote, again, pro-social behavior, largely to reduce criminal activity, mental health symptoms, out-of-home placement, and substance abuse among youth. So youth-focused intervention, but really, it's targeted at youth. We'll get to that one, between 12 to 17. It also involves their families. So it's very much, again, a family-focused therapy. And again, you can see the target populations at risk for or already engaging in these sorts of behaviors, especially youth who are at risk for out-of-home placement. So a clear fit with the FFPSA Part 1 criteria. It's intensive, so multiple weekly visits between the therapist and the family, usually lasting about 3 to 5 months. And the goals, not surprisingly, reduce the frequency and severity of problem behaviors among the youth and give them those coping skills, those pro-social skills. For the parents, caregivers, how to independently address those difficulties that can arise when you're raising children. If you're a parent, there's always issues that are coming up and you might need that support. What do I do in these particular situations? And then again, reinforcing those skills to help youth cope with these issues that are coming up in their lives. So it's addressing these core causes of delinquent or antisocial behavior by looking at what's driving those behaviors. So it starts with an ecological assessment, meaning the youth, the family, the community. So looking at the whole package. and then personalizing the intervention to target those individual drivers. So it's not a one-size-fits-all intervention. It's going to be tailored to the needs of each individual youth and family. So as I mentioned, it's going to last for 3 to 5 months. Services are available 24 hours a day, 7 days a week. So they can do crisis management. They can meet in the evenings, whatever is convenient for the family, whoever can work with them. It's a small caseload. Obviously, it has to be. You're providing this level of intensive services. You can't be serving many families at once. And they're looking at master's level. Again, pretty small, handful of families maximum. In terms of support for implementation, they have a very comprehensive implementation support arm, MST Services. And Dana, thank you for dropping that link in there. They will help you make sure this is the right program. They want you to succeed. And so in some cases, if they think that MST is not a good fit for you, they'll probably let you know that. They do have MST services that provides formal support for implementation, as well as over 20 what they call network partner organizations that they've authorized to assist. There are therapy and supervisor measures. So for the therapist, they actually have one that asks for feedback from the family on how the therapist is doing. They have a supervisor, fidelity measures, and so on. And then, yes, they do have written materials, guides, manuals that are available from MST services. So again, a fairly robust support for implementation if you decide to consider this program or go with it in more detail. Training requirements, as we said, it is master's level. And one thing that's interesting about MST is delivered within a licensed program. So it can't just be one clinician who's delivering this on their own. It has to be part of a more comprehensive entity. And so the entire team is licensed and receives training together. It is a 5-day training. And then there is more training. So there are quarterly booster sessions. There are weekly consultation calls. So this is a model that requires, again, intensive services delivered, but also more intensive supervision of what's going on during the intervention itself. Again, just to give you a flavor of the samples, we've got, African-American white African-American. We've got, violent chronic juvenile offenders. We've got sexual offenders it's been studied in, adolescents, students from, intervention classrooms, so self-contained classrooms. So a variety of different places, but all focused on the youth, the adolescent, who may be having some issues. The Prevention Services Clearinghouse identified 28 studies in their search, of which 16 were eligible for their review. And of those 16, 7 were deemed high and 3 moderate. Okay, so 10 studies that met their pretty rigorous criteria. Let's look at what they found there. All right, so not surprisingly, most of the effect was in child behavior and emotional functioning. That's the goal. They want to improve that. So we saw some significant effect there on disruptive behavior ratings, the child behavior checklist, externalizing problems, the strengths and difficulties questionnaire, conduct problems, et cetera. So those sorts of measures that are really getting more at those externalizing and conduct type disorders. They really didn't find any favorable effects on social functioning or cognitive functioning. They did find significant effect on out-of-home placement. 2 different studies that looked at decreasing an out-of-home placement rate. That's what they looked at there. They did find some small effect on substance abuse among youth, and then more on the delinquent behaviors. These were things like property offenses, any offenses, things like that. So actually getting at actual delinquent behavior measurement, usually through self-report. On the adult side, they did find favorable effects on positive parenting practices. Again, this is a family-focused intervention, so you're trying to change the entire family, including how the parents parent. So they're able to find improvements on things like positive discipline use. The Alabama Parenting Questionnaire was used in one study. They also found effects on parent-caregiver emotional health, mental health, and on family functioning in general. So this had, much broader findings. And if you were to match those up to the goals earlier, makes sense. We're trying to help the parents parent more effectively, help the kids reduce stress, et cetera. All these things are going to increase family functioning. All right, here's my sad video that we're not going to try to play. Very sorry about that. All right, so MST. So before we go on, any questions came in? I've not been eyeing the chat too carefully. I don't think I saw any, Dana.
No, we haven't had any new questions.
All right, so let's do one quick poll and then we will get on to the implementations and selection area. After hearing about these three, which of these programs are you most interested in now? Maybe you just want to learn more about it, or you're like, that might be a really good fit for my agency or our needs. All right, so we're going to give folks a minute to respond to that. Thank you, Dana, for posting that link. Okay, we'll give it another second and I think we can close it and share results. All right, so across the board, we've got kind of people who are interested in Bsft. Definitely takes the lead, but then also MST and MI. So, all three of these great interventions, a little bit different, as you can see. Everyone's a little bit different. So you really need to think about what you need, what you are looking for in an intervention. And I think that takes us very nicely into the next section that we're going to spend the rest of our time together talking about. Oops, sorry. I clicked the wrong button there. Talking about what do you do next? So implementation is another area that the CEBC works on. So I said earlier that the CEBC has both the program registry, information about programs themselves, as well as implementation and selection information. And so we're going to talk about how do you determine which program is the best fit for your own needs. And we're talking about it in context of FFPSA Part 1, but the tools that we're going to talk about could be used for any purpose. Anytime you're looking at what sort of change do I want to make or what intervention might be a good fit for our needs. All right. Let's go on. We're going to do a last poll for the day, I promise. And then I'm just curious, among our group, what experience have you had in implementing an evidence-based practice already? And so this isn't just experience delivering it. This is actually implementing it, bringing it to fruition in an agency. So it could be no experience, have not really been involved in that, could be a little bit, all the way up through expert. You have actually led implementation efforts. And so when we talk about implementation, it really is that process of moving it all the way from we picked this, and now we're going to get it through the go live period. Okay, Dana, I think we'll give it a second and then we can share results. Okay, so the majority of folks have not been involved in that, and that's fine. I think implementation is new to a lot of people, but we do have about a third of the folks who say they have some experience with this, so great. So we're going to give you some information about implementation and selection, and then introduce you to resources that are available freely on the CEBC website. And also that if you're in California, that the CEBC can also assist with some technical support. And I'll talk more about that in a minute. All right, so why does selection matter? Why does it matter which program you pick? This is probably a no-brainer for most folks, but when we talk about successfully implementing something and having it sustain, having it actually continue, it really does begin with picking the right intervention, making sure you've got the one that really does meet your local needs. And obviously, there's negative consequences of adopting the wrong evidence-based practice. And some folks may have experienced implementations of practices that didn't go well. And when you adopt something that's not a good fit, you are wasting time, you're wasting money. And unfortunately, there's my sad child picture. You're wasting, families and kids who needed services and are really not getting what was the best fit for them. Another reason why careful selection matters is that if you are an existing service provider, you're already delivering things, you're already doing stuff in your own agency. The solution to an issue may not really be adopting a new program. It might be making a change to internal processes, changing the way referrals are made, or it could be just building capacity for existing EBPs that are already available in your area. How many times have you, as our direct service providers, wanted to refer someone to a program only to be told there's a wait list? And it might be lengthy. I know we're here in San Diego. It can be 5-6 months in some cases before you can get into a program, maybe longer. So it could be that the programs exist already and they just need more capacity. It's a little bit different than bringing a new program in. And then lastly, if you're already doing something that you've developed locally or that is more a homegrown intervention that you think is working, and maybe you've got some evaluation data, it might make more sense to just build the evidence for that, to grow the research, maybe propose to get that intervention added to the clearinghouse, to get some published literature on it, et cetera, rather than just chucking it and starting all over again. We know there are a lot of programs out there that work, but not everything has been documented and well studied. And so, again, selection isn't just about finding new stuff. It's looking at what you're currently doing as well and seeing how that meets your needs. If it does, great. If not, how could you tweak it and add to it to better meet your needs? All right, so this section is going to be all about using the CEBC to select and implement effective programs. For those who are not familiar with the CEBC, here's a quick summary. So besides the sorts of information that we covered on the 3 programs earlier, the CEBC provides a lot more detail, that will help you determine whether an intervention is really the best fit for your needs, for your community needs. So you can see all the things here. We also provide, under this published peer-reviewed research, we provide plain language summaries of research studies that were used in our rating process. What we hope to do with this is provide folks that want to learn more about the research beyond just what the rating was. They want to actually see, what measures were used, what were the findings, who was this study conducted in. So we provide a standardized summary of every research article that we review. That allows you to read a brief summary, more than just an abstract, a little bit more context, without having to download a bunch of academic papers and read them. If you wanted the academic paper, we can also help you with getting a copy of that, because we know that most people don't have access to 50 different journals to access this stuff. So the CEBC can assist with that also as needed on request. The last thing that the CEBC does is you can click on a compare feature. So if you're thinking about different interventions, you can select them and compare them at the same time on each of these components that are listed here. So you can see side-by-side comparisons. All right, so here's a quick screenshot of what it looks like. There's multiple tabs across the top of the CEBC. One's the program registry, and we're talking about the implementation selection, which has concrete tools and some examples, et cetera. All right, so we also have a guide to selecting and implementing EBPs that you can download from the website. We use what's called the Ffpsa framework to support all of our implementation work. Ffpsa stands for exploration, preparation, implementation, and sustainability. Exploration is the main area where the CEBC works. This is exploring what interventions, what practices would be the best fit for your local needs. The preparation phase begins once you've selected an intervention. So you picked intervention X, you're going to move forward with it, and now you're preparing to go live. Implementation, again, is more of that go live phase. You're actually delivering services. And then sustainability, also very important to be considering from the beginning, is how are you going to keep this program going? I think an example there is if you have to fund training up front, how are you going to sustain that training over time as you have staff transition or staff turnover? And so sustainability, you need to be thinking about that from the very beginning. So we use the Ffpsa model. Let me give you an example of how we've used the guide in just brief technical assistance work here at the CEBC. So a couple years ago, we had an agency that was looking for a parent training program to include in an upcoming proposal they were putting together. So we worked with them using both the guide and 2 phone calls, so just basic phone, to identify, what were their goals for the parent training? What were they trying to accomplish? What had they already been using for parent training, and how had it gone? So again, getting at what are the current needs? What are the current services in your service array? And then learning more about the community, the population being served, age, race, gender, whatever we can learn about where you're planning to deliver these services. They then worked internally and identified 2 potential programs, parent training models from the CEBC. They did more work on their own. Again, we worked with them over the phone. They did the work. We just provided some support. They did stakeholder discussions. They had a couple calls with the program developers, which I always recommend. You're going to work with these folks. You want to make sure that you're going to get along with them. And then lastly, they did talk to other agencies who were using the models to learn more about how it went for them. And then the community, the agency, they made the final decision on which of those 2 models they wanted to go with. We just provided kind of support, direction, and guidance in the background, all over the phone, nothing in person. And so that sort of support is available to agencies here in California through the CEBC. All of the materials that we'll talk about now, these tools, are in the guide. It just requires working through them, and they're free and available to anyone, not outside of California too. Okay, so let's go through the exploration phase. What are we talking about? I'll go over some of these in more detail in a minute, but just to give you a quick flavor. The first step is that team, putting together that comprehensive team, different stakeholders, agencies, whoever is going to be involved in this effort, and always being sure that you include people with lived expertise, stakeholders, community members, etc. So it really should not be a full team of professionals. It should be additional people from the community and the population that you're looking to implement into. You're going to have to explore the problem. So again, we talked about the parenting intervention, or the parent training example that I just gave. It wasn't just parent training. It's parent training for what? What are you trying to do? Address behavior problems, address abuse and neglect, etc. So what's the goal? What's the problem that you're trying to address? And then you're looking at a needs assessment. And I see Dana has dropped some tools. We're going to have a bunch of tools that we're going to drop links to that are all from the guide that you can download and take a look at. So the needs assessment. What are you currently doing in your program or in your community? What are what's the exact need? What's your current service array, etc. Whatever data you already have. Then you identify potential solutions. So is it expanding an existing program? Is it bringing in a new program, etc.? And what might that new program be? 2 or 3 programs that might be good fits for you to investigate more fully. In that phase called Determine Program Fit, which is where you determine which of these programs is the better fit. You're never going to find a single intervention that meets every single requirement. When you look at the list of fit determinations, you'll see why. It's pretty comprehensive. We also would say it involves working with the program developers or whoever their implementation support group is to kind of establish that connection, ask your questions, see what it's like working with them. And then the last stage in exploration is always put that written summary together. So let's go through these in a little bit more detail. All right, implementation teams. Again, this is to make sure that what you're doing is more purposeful and hopefully more effective. You want to bring in, a multitude of representatives. You want to make sure that you're getting multiple perspectives on what the issues are, and that whatever you decide to do is going to be acceptable beyond just the professionals in the room, but also with parent and youth representation, community stakeholders, et cetera. So you want to get some fresh ideas and perspectives at the table as you're doing this. When you're exploring the problem, and I know that Dana dropped the exploration worksheet, again, you're getting at what do we already have? Who is the target? What's the time frame? Where is this happening? Are there geographic differences in your programs? Are there, a lack of services for a certain age group, et cetera? You always want to start with what data you already have available. Whether it's the child welfare system or a community-based provider, you likely have individual data already, or your own data. You could also start looking at publicly available data, at the county level. Basically start with whatever data you have available to you already. Okay. Another thing that we often recommend is doing some root cause analysis. And this can be something very formal, like a fishbone diagram, or we often just use what we call ask why 5 times. So it's in that implementation team. Start talking through the process. So here's an example that we had from a county where they had concerns about children who were re-entering care after reunification. And in this county, they had 3 different contractors providing aftercare services, and they were allocated geographically. So depending on where you lived, determined which of the providers you got, and all of their services were a little bit different. So when we had them asking these questions and looking at data, they had to go an extra step, which was to look at the differences between the contractors and the regions they were serving, to try to see if there were differences in the re-entry rates between those organizations. So in this case, the general kind of questions is, why are kids re-entering care? What's the problem? They were getting, obviously, new reports to child welfare. They started looking at some data from that. What was driving those new reports? Largely substance abuse or parental arrest. All right, so let's back up on that one. Most of these parents who they reunified with already had issues with substance use at the first episode. Okay, so let's start talking about what are the other risk factors. They found that many of these parents had themselves been in the child welfare system when they were youth, and they reported having a lack of positive social support. They didn't have a strong network of natural support. So once they left child welfare, they didn't really have a great network. They were seeing a lot of dropout from aftercare services. So even when the services are available, this is great, this county had this program, it doesn't mean that everyone engages in services. And so why? Lack of engagement, lack of follow-up. So what's the process for, when someone doesn't show for services? What do you do? How many times do you try to reach out to them? What is the engagement process? Are they using something like motivational interviewing, et cetera? And so by asking these questions, in this case, what they found is they didn't just need a new program. Bringing in a whole new program probably wasn't going to make any difference. They needed to address the engagement issues first and make sure the current services were being delivered well. And so they changed the way they did the engagement. They changed the follow-up process. They made sure that they relieved some of the burdens on parents of getting to these aftercare services. So if you're going to provide services for parents, doing things like, assisting with childcare, assisting with transportation, providing dinner. If the meeting is at dinner time, then provide a meal, like whatever you can do to help families engage. And so in this case, they never went on from here. They shored up what they currently had and stopped at this point. But many people then will realize that they actually do need to bring something different in. And you would go on again to that needs assessment piece, examining what's going on. And I think we're going to drop a link to that. It's more about the problem. It's more about the data that you currently have. And then what's that plan going to be to address the gaps and the barriers that you see, identifying who those underserved populations are, et cetera. Then we talk about what are the potential solutions. So in this case, this is very CEBC oriented. It would guide you through identifying some key terms that you're looking for, doing some searching on the CEBC to determine what types of programs would be the best fit for your needs. Now, FFPSA Part 1 has given you a short list. It's given you 3 substance abuse interventions. You can use, the information on the CEBC or the Prevention Services Clearinghouse to help see if any of those 3 is a good fit for your needs. And if not, you might look at, using the broader funding under AB 153, that state block grant, to utilize that dollars to support an intervention that's a better fit for your needs. The selection guide has both a very detailed text guide and then a worksheet that will help you identify the programs that you're comparing and then take some notes. Again, this should be a process in your implementation team. It's not just one person. This could be a whole meeting. We're going to spend a meeting just working through the selection guide for the 2 interventions that we've picked that we think are potentials. And let me run through what these are. These are basically domains you want to consider. So things like ease of use. How hard is this practice to use? How complicated is it? Match of skill sets. Does it fit with my existing staff that we have? And we could just kind of turn them over to a new program, train them, and they can start delivering it? Or am I going to have to hire a completely different staff in order to deliver this intervention? So let's go through a couple of examples, but these are, again, in the guide, we've got detailed information on each of these domains, real world examples and also where you can look on the CEBC website to find information about this. And when you're going through the selection process, you really do want to look at all of these. And that's why I said earlier, you're not likely to find one intervention that is 100% fit on all of these. There's always going to be a little give and take of what you think is the closest intervention for your needs. So let's just, I think we have time. Yeah, we'll go through a couple of these. External compatibility sounds very formal, but basically it's how well does this practice fit with the beliefs and values of the community and clients? You guys are on the ground, your staff, you know your own population better than any program developer can. So when you look at this intervention, you have to kind of think as that implementation team, is this actually a good fit for what our community wants and needs? Or are we making a step too far? And so only you at the local level can answer that. Is it also compatible with referral sources currently in place? Will they feel comfortable referring clients to it? How much education do you need to do to the referral sources to get them to send people to make the referrals to you? So you might want to think about things like duration and intensity of the practice. How is it delivered? How is this going to work? But again, all determined at the local level, questions you want to be asking in your implementation team. Obviously, things like financial considerations, what they call relative advantage, are important. What are the financial resources? So we've got money under FFPSA Part 1 and under AB 153. Not sure it's going to last forever. So could this fund, be funded in some other way? You don't really want to get into a situation where you're partway through training and then you realize that the cost to implement the EBP is beyond, what you budgeted or what you were planning for in the grant proposal. If you don't have access to additional funds, or you didn't anticipate costs for things like ongoing training due to staff turnover, you could get stuck. And you may be able to go back to the funder and see what the options are to course correct, but that's not always possible. So you want to think about that from the very beginning. And the last one, that relative advantage, is this program a lot better in terms of efficiency or cost efficiency, outcomes, than what you're currently doing? And so that really gets at, what's it going to cost you to move to a new program? And is that really advantageous compared to what you're currently doing and could sustain? All right, last one, skill set, which I mentioned. This is probably less an issue for this domain, substance use, because if you already have a substance abuse treatment or a prevention, the education levels were pretty probably pretty similar to what we saw here, but you do want to think about it more broadly. On the in-home parent support topic, we talked about how some of them require nurses. If you don't have nurses on staff, then you have to let go of your existing staff and hire nurses, which may or may not be a problem depending on where you work and what you want to do. So education level, skill set, what's the existing workforce in your community, and are you able to recruit staff? So if it requires a master's degree, are you able to recruit master's level clinicians? And again, you only know that from what's happening locally on the ground in your area. The last step of this exploration phase, as I mentioned before, is always going to be documenting how your team, how that implementation team came to its decisions. And again, this is so critical because this is not a process that's going to happen in one meeting. There's going to be probably a series of meetings, groups getting together and talking about this. And we know there's turnover. We know things change. So you want to make sure that you're documenting clearly how you came to that decision, why any particular program was selected, what the buy-in was, who attended, et cetera. And then that also allows you to kind of transition your implementation team with maybe some shifts in the composition to the preparation phase, which is kind of the, what's the plan? How are we going to actually begin implementing this, training staff, et cetera. And the preparation phase is much more specific to the individual practice. And so at that point, you'd be working again with those implementation providers that we talked about earlier, which could be the developer or another intermediary that they've worked with to support implementation. Okay. So that's a brief summary. All of this, again, in the guide in more detail. I'm just going to touch on a couple of common barriers that we see in implementation. I think by far one of the biggest issues that we hear about is staff and community buy-in when there's a new practice. And again, this is a reason why we suggest using that implementation team and involving staff, involving stakeholders. This cannot just be a decision that's made at the administrative level or the executive level. It needs to involve the practitioners and the community, because you want to head off any of these concerns about fit by actually getting those folks involved from the very beginning so they can give their input on what they think is the best practice. Fidelity is also typically a major concern. You want to have a clear plan from the beginning, and you'll do this working with the program developer, but you want to know how you're going to assess it on an ongoing basis. And also, what do you do to address it if you start to identify issues? So what is the program? What is the practice of the programs you're looking at if you do see that there's been a slip in Fidelity? Is it retraining? Is it booster sessions? What does that look like? And have you budgeted for that? Hopefully the developer could give you an idea of how often that sort of support is needed. But again, it can, it's a financial consideration as well. The last implementation question that we always get is about adaptation. And do I need to adapt? How do I adapt, et cetera? So the first thing that I'm going to say about this is that first, determine whether you even need to adapt prior to program implementation. So first, you may want to consider just trying the original model. You may think, oh, I have to adapt this to fit my population. You may not really need to. You want to work with the program developer about this because they're going to have the best information about where has this program been used, what samples, has it already been adapted in any way? Has another site already done something, another program? You also want to work with the developer because you want to be really certain that anything you change is not going to change or impact on the effectiveness of the intervention. You don't want to so-called ruin the intervention by changing something that was actually crucial to what led to its effectiveness. Okay. So let me give you some examples. When we talk about adaptation, it's common to kind of see this red, yellow, green kind of indication. So what we call green light changes are usually minor. These are things that you might do to adapt the intervention to your community. So this might be calling it by a different name. Maybe you don't want to call it brief strategic family therapy because that sounds wacky. Maybe you want to call it strengthening San Diego families, whatever. Changing a name, not a fundamental shift to the program. Or you want to take the program materials and you want to change out all the images so that it reflects your population. You want to change the wording of some scenarios. Again, make it more reflective of the population that you're working with. Those are things that are usually considered pretty green light. You still want to run them by the developer, but usually not problematic. Yellow light changes are when you're adding or modifying an intervention. So this could be additional activities. This could be shifting the sequence around. It might be changing the delivery format, moving who delivers the intervention, etc. So again, these could be questionable. If you were to change from a master's level clinician to a bachelor's level clinician, there's a difference there. There's a difference in expertise and training. And so you'd want to work with the developer to make sure they're comfortable with the sorts of activities you're doing. Typically, though, adding something to an intervention is less concerning than what's in the red light area, which is deleting. Anytime you're taking stuff away, that's when you really, really want to be concerned. So cutting out a module because you don't think it's a good fit, not a good idea. Definitely talk to the developer first. Maybe you could make some revisions to it. You can change the order. You can tailor it a little bit. But anytime you're taking out a core component, an entire module, you're cutting it, you're cutting the timeline. So let's say it's meant to be delivered once a week for 18 weeks, and you want to deliver it 3 times a week for 6 weeks. Again, it's a fundamental change. So you want to talk to the developer because those are more concerning. It may be that it's once a week for 18 weeks because you want to give the participants time to kind of practice those skills. And by shortening it, you lose that ability to kind of learn one thing at a time, integrate it for a week, and then move on, et cetera. All right, so that's very, very brief introduction to the idea of adaptations are okay in conjunction with the developer and done very thoughtfully. All right, so that is the end of our summary of the selection process. Again, all the materials are on the CEBC website. You can contact us if you're in California. We can do more individualized support for you. And our information is there on the screen. And so I will turn it over to Dana to see if there are any questions before we wrap up for the day.
We have no new questions.
All right.
Does anyone have, so there are no new questions in the chat or in the Q&A. Does anyone have any questions that they'd like to add?
Well, obviously, if you have questions going forward, you can contact us at the CEBC. You can reach out to us through CalTrin. We're actually all part of the same organization. So get your question to either place and it'll get to me and we'll get back to you directly. All right, so I'm going to go ahead and put the last slide up now. Dana, you can take it away.
Thank you. Jennifer, we really appreciate your time this morning on well-supported substance abuse prevention and treatment programs. We will have the recording and all of the resources, including the videos that we missed this morning, going out within the next 2 days so that you can have a look at them. They'll also be available publicly on our website, together with the webinar recordings from the review of the mental health programs and the in-home parent skill-based programs. So all in one place at caltrin.org. I have dropped the survey for this webinar, and at the end of that survey is a certificate if you would like one. We do take all of your feedback very seriously, and it really does help us to schedule future programming. Finally, watch your inbox for the next issue of the CalTrin Connect so that you can plan to register for more training. That will be coming up on next Thursday. You'll be seeing that issue. If you have any questions, I will drop our information email address into the chat, as well as the survey one more time. Thank you so much for joining us.